light just on. Shorter, you have a question, or your light's just on?
Of the agency.
Next time, okay. Commissioner, you're recognized. Go ahead, and then we'll entertain
you.
questions. And I know Senator Nichols had a question.
Good afternoon. I'm Dr. Jennifer Schufert. I serve as the Commissioner at the Texas Department of State Health Services, and with me today is Christy Halverburton, our Chief Financial Officer. I am honored to have the opportunity to lay out the department's legislative appropriation request before you today. If you turn to slide 5, in the interest of time, I'm going to jump right into Senate Bill 1 and its impact on our exceptional item requests. So on slide 5, you will see that Senate Bill 1, as filed, fulfills 2 pieces of our original EI requests, our request to cover data center services costs and 7 FTE slots to support 2 maternal health data systems that we are building. Article 9 also states that the supplemental bill will cover our vehicles request and one of our top priorities, new lab space on our DSHS campus to address the growing demand for our public health lab services. I am so grateful to you for your consideration of our agency's needs in Senate Bill 1, including our need for lab space. So thank you so much. Now, if you flip to slide 7, you will see a summary slide of our exceptional items, but I'm going to walk through these quickly one by one. If you go to slide 8, you'll see our first exceptional item, which focuses on maintenance of existing agency operations. So this includes covering the business costs of things like staff, computers, and software. As I just mentioned, Senate Bill 1 indicates our vehicle needs will be met through the supplemental bill, so thank you. This EI also includes a request to cover the operational cost increases of our tuberculosis hospital in San Antonio, the Texas Center for Infectious Disease, or TCID, where we are experiencing increased costs for the medications, food, and utilities. On the next slide, slide 9, exceptional item 2 is focused on the costs of operating our brick and mortar locations throughout the state, which include our public health labs that we have here in Austin and the one down in Harlingen, TCID in San Antonio, and public health field clinics throughout the state. These funds will help us with deferred maintenance, health and safety projects, and increased lease costs. On slide 10, you'll see our third EI, and this has to do with support for new lab space, which we've already talked about, and thank you. So, but also on this exceptional item, we're requesting 38 lab FTEs that we need in order to stand up 5 new newborn screening tests on our newborn screening panel, as well as incorporating PFAS testing into our standard water supply testing. So PFAS are those forever chemicals that can contaminate water supplies. These are fee-supported tests, but we just need to increase our FTE slots to accommodate the staff to run the tests. On slide 11, you'll see exceptional item 4. This item is focused on syphilis in Texas moms and babies. Syphilis in general has been increasing over the last decade, but congenital syphilis, which is syphilis that's passed from a mom to a baby during pregnancy, has risen dramatically in Texas since 2017. In 2023, 930 babies were born with congenital syphilis, including 52 that were stillborn or died shortly after birth. Babies that do survive can have long-term health complications. Effective treatment can reduce the chances that the babies will be affected by as much as 98%, but many women have challenges completing that treatment, and physicians have challenges taking care of these moms and babies. So the exceptional item is aiming to increase awareness and resources for both women and for the providers who need additional supports. On slide 12, you'll see exceptional item 5, which addresses 5 foundational public health services. So while public health can include many components, certain public health services are foundational to community health and safety. And these services include functions that can't be conducted by private sector or are offered as a safety net. 5 foundational components of public health services are related to STDs, TB, rabies, social services, and immunizations. Now, as the state grows, meeting the demand for these public health services is very important to protecting the basic health and safety of Texas communities. Turning to slide 13, EI6 focuses on Texans and Texas businesses that serve as the backbone of our economy. So many of the industries that we regulate, DSHS regulates, must meet federal requirements. So we put a lot of effort into training highly skilled staff that can work well with Texas businesses. And increasingly, we are seeing these highly trained staff leave for jobs with federal agencies or the private sector due to higher salaries, especially in our meat and our radiation safety programs. And then for our EMS industries and community health worker registration programs, we are asking for staff so that we can keep pace with the incredible growth that we're seeing in both of those sectors. On slide 14, EI7, this is about preventing tobacco-related death and disease. Tobacco remains the leading cause of preventable death in Texas. We have seen that targeted messaging drives individuals to our Texas Tobacco Quit Line services. And then our data shows that on average, about 35% of those quit line callers actually quit smoking in 6 months. On slide 15, you'll see EI8, which relates to the maternal health systems that you funded us for last session and would allow us to continue to improve the quality of data for maternal and child health programs that DSHS oversees. Also included in this EI is our birth defects registry. We're charged in statute to collect this information. The number of staff that we've had in this program has remained stable since 1999, while the number of birth defects identified has doubled during that period of time. So we're just getting behind in the collection of this data, which means that we're less equipped to understand the current trends in infant health. And then finally, on slide 16, EI9 would implement a modernized software system for licensing, inspection, and compliance activities to improve customer service for more than 300,000 businesses and professionals that DSHS is required to license and regulate. So in conclusion, thank you for the opportunity to address you today. You can find more information on these requests in the appendix behind my presentation. And I look forward to working with y'all and your teams over the next few months. But please let me know if you have any questions at all.
Thank you. And Senator Nichols, did you want to ask the agency, because I had cut you off? Well, I didn't cut you off. I just wanted you to ask the right
That's okay.
Yeah.
They are not supposed to really address the policy. So
Exactly,
I
but
should
you
have
go
waited.
ahead, yeah.
But you heard the question. In the beginning, when that program started, I don't know, 2 or 3 sessions ago, the whole idea was to help get some of these federally qualified centers up to speed so they could get certified, and then they're pretty much freestanding, take care of themselves. And during that vulnerable period, it's really, they're so dependent on doctors doing pro bono work and stuff like that, which there's a lot of great doctors that do that. But when we got the funding, the first out-of-the-box report we got on how it was going to be expended were existing federally qualified centers stepping up saying, well, we can expand our services. Mm-hmm. And so the great bulk of the funding was going to go to that. And I know some of us got involved and they went back and did it the other way. In other words, use those for the first money for centers on the startups, and any left over could be used to expand service. So how are we doing on that?
So I can have our program get back to you with all of the specifics, but I can tell you that we have been prioritizing funding for new startup FQHCs or FQHC lookalikes, and that we've had 2 that have become FQHC lookalikes. We have 1 that's awaiting an inspection to be one, and then 2 that are still working on that. And so overall, I know that we've had those 5 that are working on that status. And then we do have additional number of FQHC lookalikes or FQHCs who already have that status, who are using the funds to.
I would like to see somebody's got this. We're not dealing with a large set of numbers here. When we started doing that, how many were we're trying to get certified stage to they finished, and how many more have we got there in that mode right now? And how much money overall went to them versus expansions of existing services?
Yeah, we can definitely get you that information. You don't have that.
And I don't know if there's been an outreach at all to some of these startups, because I know I've talked to some that said, well, I didn't know that was even available.
Yeah, we've tried to work really hard for outreach to make sure that people know about this money, and we'll continue to do that.
Thank you very much.
Yes.
Senator Schwartner.
Thank you, Madam Chair. Along the lines of the FQHC, do y'all have regulatory authority over the FQHCs? Do y'all license them? I can't recall.
I don't think we do. No, we don't license any clinics.
But y'all assist in startup money through the program, but also direct funding in some respects?
Christy Hovel-Burton, Department of State Health Services. We do provide the funding for kind of startup money. Additionally, we have some other funds to help expand access. I'll have to get back with you more on the licensing side because I don't remember which entity licensed them.
There's a current state law requiring hospitals to check legal status when they present to the emergency room. Is that the same as in FQHCs?
I don't know that offhand.
Yeah, it's not. And FQHCs have about 25% that are essentially Spanish speaking only when they present as their primary language. And I respect FQHC's mission, but it has been a significant source of health care for the illegal immigration or illegal immigrant population here in Texas. It's been, and I don't know if that really is consistent with what's going on federally and also in our state. Texas is home to 14% of the illegal immigrant population in our nation. And it is things like FQHCs. There's other things too. You have emergency Medicaid. You have SNAP is not eligible to illegal immigrants, so WIC is. The state HIV Medicaid program is, and then there's women's health programs through the community health centers. It's about $2 billion in our state budget overall. It's not insignificant in GR money. So I'd like to know the exact answer as to whether or not y'all check eligibility or immigration status as required by state law for hospitals across the state when it comes to FQHCs. And I've asked Ms. Young and the commissioners to give a detailed amount of money that flows to programs for which non-citizens are eligible, illegal non-citizens are eligible. And that's unfortunately because it's hard to do because some are through HHSC, some are through DSHS, and some are actually some are actually through Article 3. But I think it's important for this committee to know that it's about $2 billion from my recollection about in the various programs that are out there in Texas. And that is, of course, a policy issue that we need to discuss moving forward. We are doing a lot at the border, but if we want to do something on the inside, it does take some effort and some hard decisions. So thank you.
I can answer the question for the hospital that DSHS runs, so the Texas Center for Infectious Disease, and we do check that status when they're admitted.
Yes, for the hospital, but as required by state law.
Yes.
Yeah, but other hospitals, private hospitals have to do so as well. FQHCs, again, are primarily federally funded, but they are not, I don't believe they are required to do so. I don't think there's state law requiring that. I don't know if they can implement that, but I do know there's a large portion that do receive care through FQHCs that are primarily 25%, according to the data, that are Spanish speaking only, that has some correlation to immigration status.
All right, Senator Perry. In Hall.
Chair.
See you down there. Well, you think I forget you, but I don't.
No, I knew you weren't going to forget me. I think Senator Nichols got the information on the FQHC. Please copy me on that. I assume the members could do that. On the 28, on 14, the hemp deal, a conversation, if we are successful and enforcement steps up, I think there's $2.6 million in the current biennial budget, right? Is that correct for enforcement?
I believe so, yes, on the
1.3 each year, I think, or something like that.
Yes, sir.
Not today, but if that bill passes and you need additional money, kind of give us a forewarn before we get out of here to kind of let us know, because we're going to need to be very aggressive in that effort and send the message. 32, the spade neuter, as you have that $5 million granted to you for disposition, I can't override the current designation, but I would encourage you to get with veterinarian versus animal health. The veterinarian has the program for spade or neuter, running it through A&M's veterinarian school, Tech's veterinarian school, and other places already in place. So this is their wheelhouse. Does that make sense? You mentioned PFAS.
Yes.
Tell me, so y'all do the actual testing, TCQ collects the samples, correct?
And TCU promulgates the rules, and then we do the water testing. We test about 60% of the water supplies. LCRA tests the other.
Okay, so between 60 is y'all's and 40 is LCRA. Are they going to be stepping up the PFAS?
It's my understanding.
Is this a federal requirement
It is.
coming down the pike? Was it attached to federal money the state gets? You don't know.
Not that I know of.
No, sure.
Yeah.
Well,
Not that we've received.
just at 63, I know I've drank 63 years of PFAS. Just so you know, it's another one of those requirements. I'm not discounting the validity of things we drink ought to be clear and clean, but for the most part, we've been drinking this stuff for a long time, and this is what feds do, especially to TCQ. They keep ratcheting up the standards only to cost the consumer at the end of the day responsible for paying drinking water to pay the tab. So I'm not suggesting to you there's things in it we need to know about, but at the same time, they're wanting to get rid of fluoride. Well, I can remember growing up that you couldn't get enough fluoride in the water. So which is it? But this is the game we're playing. But it's your responsibility to do the sampling, and you believe it's attached to federal dollars, correct?
I don't believe it is attached to federal dollars. If it is, it has not federal dollars that we've received.
Okay, all right, thank you. And just back to Senator Swertner's question, my Lubbock FQHC does ask for immigration status, which I'm kind of surprised because federal FQHCs, I would have figured federal prohibited it, but they do, at least in Lubbock, ask for that immigration status. So they may be in violation of a federal law, I don't know, but they do ask.
They don't do that at federally funded LQHCs.
Well, I didn't think they would, but
It may ask.
I don't know whose
They-
information you're getting that from, but it's not correct.
the director, they asked from the immigration status. Now, whether they get an
The
answer,
director of that clinic?
yeah.
I think they're just telling you that.
Well, I'll find out because I don't want to be lied to either way. But I was surprised because federal you can't. I didn't.
They
think.
want
We'll see.
to, what's the director's name? I'll give him a call.
Now, Schwertner, don't start any trouble.
I will. I will text you that name and his contact.
That'd be good.
Okay.
Okay, well, all righty. Senator Hall.
Thank you, Madam Chair. Just back under your exceptional item there, you've got 3 boats and 26 vehicles. I assume you don't plan any of those to be electric, do you?
No.
Okay, just want to make sure. Thank you.
Well, that was easy. Senator Flores.
Thank you, Madam Chair. So my question is just basically about tuberculosis. So as my understanding is from my own personal physician who practices in Rio Grande City, that there's a very virulent strain of tuberculosis prevalent in Central America and the Caribbean, but that we have very little immunity with over here in the United States. Of course, in the Caribbean, tuberculosis is high except for Puerto Rico because, well, it's American territory and we do things a little different. So with the influx of aliens that have come from that area, from Central America, from the Caribbean, but more especially Central America, have you seen a rise in that? There was a tuberculosis cluster that just broke out in Kansas, where a lot of folks go to, those meat packing plants up there. But so are you seeing that or a real and present danger of that virulent strain of tuberculosis here? Or have you seen an uptick in tuberculosis given the population that has come from there into our nation in the last 2 years?
So we've seen increased cases of tuberculosis, and nationally, there's been an increase in tuberculosis cases. We have had kind of I believe what you're talking about is a particularly resistant strain, a drug-resistant strain that is circulating in certain countries right now. And we have had some multi-drug resistant and some extensively drug resistant tuberculosis cases here in our state. They have not been increasing in recent years, but we do experience them, and they are very complicated to treat. And so we're on the lookout for those. We do kind of genotyping on the tuberculosis strains that we isolate or culture and isolate, and so that we can look for trends in those sorts of really drug-resistant cases and see if they start to cluster, but we're not seeing that right now.
Okay, thank you, Madam Chair.
Okay, Senator Zaffarini.
Thank you, Madam Chair. To begin with, on page 8 of your document, I'm looking at your increased costs. Are those costs prioritized? Are they provided in your priority order or need?
Yes, the increased costs have been prioritized.
What is seat management? Why do you call that seat management?
Seat management is the cost for like the rental cost for your computer and all of the like Word, all of the Microsoft suite that's on it, as well as your additional software and some of the other hardware associated.
Seat management?
It's called seat management, ma'am.
New to me, thank you.
Yeah.
And regarding the line item therefore, whether the information for Texas Center for Infectious Disease, what medical resources are you addressing there?
This is our tuberculosis hospital, so these are increased costs for medication as well as just the increased medical costs that facilities are having impacted at this time.
Thank you. On page 11 of your handout, regarding congenital syphilis, it seems to me that everything you list here is identified under prevention and treatment, but it's mostly awareness. What in your listing refers specifically to prevention?
So
Treatment, it's just, what I see is just all awareness and education.
So some of it is awareness and education, but there is prevention and treatment. So the awareness and education is because, syphilis decreased to such low levels around 1999 that people kind of forgot that it was out there, the public and healthcare providers. And so increased awareness for both the public and healthcare providers to be able to diagnose that. But then also, by treating these moms, we prevent the spread of that to the baby. And so you will see there that there is a established rapid response regional nurse teams to ensure mothers in all areas of the state can easily access and complete treatment to protect their babies from congenital syphilis. And so that includes delivering treatment to women so that we prevent the transmission of syphilis to their baby. We also, in the second item there, talk about standing up congenital syphilis consultation hotline. And this is because a lot of providers will get a patient in their exam room and they might have a test result, but they don't know how to interpret that test. They don't know how to stage syphilis or how to give the right treatment. And then furthermore, when the babies are born, they don't know how to manage those babies and follow them through time. And so our consultation helpline would then help them get the treatment they need and the follow-up they need.
Thank you.
Sure.
On page 12 of your handout, you talk about sexually transmitted disease, tuberculosis, and rabies. Could you tell us something about the trends for those three areas over the last few years and what you project?
So with sexually transmitted diseases, we're seeing kind of a flattening or slight decrease of chlamydia and gonorrhea. Those trends are both in Texas and throughout nationally, but we're seeing increases in HIV and in syphilis. And so concerning, and again, what we're seeing,
Uh-oh.
Y'all can't hear me.
Here, let me turn it on and off. Try again. At work?
Oh, yeah, there I am again. Okay. For HIV, we're seeing increased cases, and then we're certainly seeing increased cases for syphilis. And again, that's a national trend for both syphilis in the adult population and congenital syphilis. For tuberculosis, we're seeing increased cases. We saw a drop in diagnosed cases during the pandemic, likely because people just weren't seeking care. But we've seen the cases now exceeding what they were pre-pandemic. And again, a trend that we're seeing nationally, not just here in Texas. And then for rabies, we are seeing some worrisome trends in animal rabies just on the other side of our borders. And so We've spent time over the last 30 years, honestly, trying to create a buffer zone along the Texas-Mexico border to keep dog and coyote rabies from coming into our state. And we've been able to create this buffer zone and maintain it over time. Right now, we are still seeing that there is some dog coyote variant rabies just on the other side of the border. And so hoping to maintain that buffer zone that we've got right there and extending it towards El Paso and surrounding El Paso, because we know that New Mexico is having more Arizona gray fox variant that is coming really close to our border there. And so asking for additional money to maintain that buffer zone. We do that by putting some oral rabies vaccines. We drop them from airplanes and then animals eat them. Foxes and coyotes will eat them, and it's a vaccine for them, and it creates this buffer zone and keeps rabies from an incursion across the border and infecting people or livestock or other animals. So that's been successful for the last 30 years, and so we're asking for some funds to continue that. And then the prices on vaccines and immunoglobulin, which we provide to people who don't have another source after they've been exposed to rabies, is also included in our exceptional item request.
So do you drop those rabies vaccines on the other side of the border?
No, on ours.
Our side, they cross, okay.
Yeah.
I was just wondering if we were dropping.
No, we're not. And actually, there is, if you go to slide 31, you can see a map of where we have, where that buffer zone is and where we have previously dropped baits and where we are hoping to increase our coverage just to prevent those rabies cases from coming from New Mexico border.
Okay, thanks. I mean, go ahead, Senator Zaffirini. I just
Thank
know
you.
about that.
On page 13, at the bottom right, you talk about reviewing applications for instructors. What can we do to streamline that application process while maintaining safety and competency standards?
I'm sorry, can you repeat the
The
question?
bottom of the right, see on page 13?
Yes,
You refer to community health workers?
yes.
And hiring FTEs to review applications. And my question is, what can we do to streamline that process while not sacrificing standards and safety?
So right now, just a little bit of background. Between 2019 and 2023, we had a 65% increase in the number of people seeking this certification. So we've just been somewhat inundated with applications for certification. And so we have a process to certify these folks, but because of the extreme increase in interest, we are just getting behind.
Thank you. On page, I can't find your page number here, I think it's 14. You address the issue of tobacco-related cancers, and you specify that you would target the group between the ages of 30 and 64. Why not minors? We've made such a to-do about minor smoking. Have we seen a significant decrease in minors who smoke?
We have seen some decrease. In our last session, we did an exceptional item where we were focusing on youth, and we've been able to bolster some of those programs and make sure that we've got continuing community engagement with them and training and trying to get those youth to our hotline. We also know that this group of 30 to 64-year-olds are typically cigarette smokers, and that these really intense preventable health consequences of lung cancer and vascular disease can be prevented if we can get them to quit smoking cigarettes. And so these efforts are focused on that group to reduce the preventable death that we're seeing from cigarette smoking.
So you would expect a similar decrease with the adults?
We're hoping,
You would
yes.
hope so. Thank you. On page 15, did I hear you say correctly that birth defects have doubled?
Yes. And so that's a combination of just the population growth that we've seen in our state, more people having babies. Because over that period of time that I was talking about, we've seen a 40% increase in our state population. We're able to identify more of these birth defects now. And so between better case ascertainment, being able to identify them plus the population growth, it's resulted in that sort of increase.
Do you know what is causing those defects?
I can get you a breakdown and we can send that to your office. Our last complete year of data is 2021 because we're a few years behind on collating all of this data, but we can get that.
Thank you. Thank you, Madam Chair.
Thank you, Senator Colcourse.
Thank you. LBB's presentation, page 1, 769 reduction of FTEs. That's a lot.
Yeah.
I mean, that's Doge 101 right there. But I just want to ask a realistic question. They were funded by the COVID dollars, ARPA and other funding streams starting in 2020. How do you take 769 people and really remove them from your organization, your agency?
So,
Or were they contracted? Did we contract?
most of them are FTEs. What we're actually doing is the COVID FTEs were removed from the introduced budget. That happened this last session as well for the 24-25 biennium. And then there's that Article 9 provision where we submit a letter related to fully federally funded positions to request like a temporary increase for these essentially one-time positions that are funded with these one-time federal funds. Since some of our COVID funds don't end until 2027, we're continuing to see this number decrease. So while the full 776 was reduced, I think their first page also includes what our estimates were for 26 and 27. I think it was maybe 626 and less than 27. We're trying to do as much as we can with attrition first, of course, and then go from there. We're still sort of reviewing it as these COVID grants are ending.
So I take all of that to say that we still have a lot of people still on board from COVID. You still have federal dollars that you're using, and I'm extrapolating from that whole conversation. And then, but you are going through attrition and other ways to reduce those numbers. So
Yes,
at the
ma'am.
end of this next biennium, you will have 769 less employees unless we give you something through the process from between now and the end of May.
Compared to today, about that much. Of course, they were already reduced from 26, 27.
Right.
I will say there are some additional administrative positions that'll have to remain for a little bit longer, just a couple lingering kind of positions because you still have the audit process and the grant closeout process that'll take another year or two. But that's nowhere near that 700 number.
Okay, great segue into leftover COVID dollars that I think, Commissioner, were very wise to approach the chair and myself and some others about, wow, I mean, it was real dollars. I think it was like 400 million-ish, maybe more, 600?
More than, yes.
How much was that?
Around 750 million.
Oh,
Yeah.
750 million that we were, y'all were trying to get out of the door, which, just as a taxpayer out there listening today, it's, how many trillion are we in debt in the nation? So I appreciate y'all because you really had the authority. You could have just done it. Okay. So we went through all those lists. You were working with higher ed to get them some monies. How much of that did you spend? How much did you give back to the federal government, which hopefully through Doge, they're giving back to the people or reducing our debt in our nation? How much?
I would say it's still going on. The full grant was 1.5 billion and we've spent 700 million to date. So that's an additional 800 million. The grant ends it's 2026, summer of 2026. So we're continuing to spend down the projects that were approved. Not the full list we submitted was not approved.
Right.
So it wasn't that full amount.
So I think Senator Huffman, you and I worked, we X'd urine samples in our wastewater. So do y'all do any wastewater surveillance?
Yeah, we had a grant from CDC that started maybe in 2020, maybe in 2021. So we had a pre-existing one, and that's part of the kind of the national network of wastewater surveillance. And so that's a smaller one that CDC has maintained for us. And so we do have some wastewater surveillance going on.
What do you look for in that?
So it initially started as COVID, but that's what it came out under. At this point, we look for flu, influenza. We can look for H5N1 avian influenza and seeing if we're seeing increased cases of those, and Mpox.
Okay, and one of the concerns being you use that data surveillance is a strong word, not a word that is looked upon fondly in Texas, I would say. I do have concern as we move forward, and I know that Teffy, based at UT Houston, they do a lot of surveillance with wastewater. Is that correct?
Yes.
So as we look at Teffy, it seems to be mission creep between y'all and them. You're not going to answer this question, but I'm trying to figure out, Madam Chair, if we're Doge and we said, wow, I think there's a duplication of effort here.
Yep.
What say you, Commissioner? Enough said. So I have another question for you, which, since we're on the topic of COVID, you and I have discussed different databases that y'all have. You have immunization databases. Am I correct on that?
Yes, we do.
There's a lot of information, newborn screening, different things. I know data, we're entering this world of AI. We're entering this world of, data drives our decisions. Is there any place in America, it seems like this is going on in Europe, it seems like it's going on in other countries where they're using these databases not just to look at adverse reactions, which I think we did a terrible job during COVID. I think it's one of the greatest cover-ups in our lifetime, maybe in the span of the world, that we did not really follow adverse reactions during a mass immunization effort across our nation. But are any researchers looking or asking for data that we could compare outcomes in the future? There's no debate. You and I have talked about myocarditis, especially in males, younger males. Is anyone using y'all's database, or can they, to start looking at and saying, wow, we're seeing certain things, certain trends we need to be prepared for, we need to understand the long-term effect of mRNAs? Anybody?
No, so our database is our vaccine registry. And so we did document people who were receiving that vaccine, but we didn't take the side effects or complaints or anything after vaccines. That's not part of our vaccine registry.
only a
That
federal.
would go to the federal. And so I don't know if anybody...
That's CDC or that's CDC?
It's a combination between them. It's VAERS, and so FDA and CDC share responsibility for that that database and those investigations. And so nobody is using our data currently. There's some really strict authorizations, around.
And you and I have
data.
talked about that there's really a lot that we could learn and glean from if we look in the rearview mirror.
Yeah.
Doing my own research after 1917, there really wasn't. It was really an interesting phenomenon that no one wanted to look in the rearview mirror. Am I correct
Exactly.
on that?
Yes.
That's all the history. And I've said for a long time, Madam Chair, we probably should do what's called a war college and look back to see what we did right, what we did wrong, and be able to incorporate that to document it so well for I hope that there isn't one. I hope we're that good in the future, a pandemic. So I look forward to working with you on that, which is the last segue into databases, which we made the decision as a body last session to fund, I'd call it MMRS, am I correct?
Yes.
And that is, if you would explain what it is, and then I want to ask a question about that. So it's taking the data on maternal mortality and health and doing what?
So this system it's one that we designed to meet our needs for Texas. And so it will take in the case data. And so when a woman dies, there's a maternal mortality, so dies within some time during pregnancy or the year after, we are able to put those records into this system. We're developing the system so it can auto redact, and so redact out a lot of the identifiable information. it maintains those records, and then allows reviewers to look at that data within that system and do their case review within that system. They can pass it from person to person within that system. We can follow progress, who's looking at those records. Afterwards, when the reviewers have all looked at the cases, determined the cause of the maternal death, we can then do analysis on it as well using this system and its connection to our large data analysis platform. And so all of that is kept within this one system. That is really a remarkable system.
And is Texas the first state to really do that instead of just sending it to the CDC?
So most states do use the CDC system, Maria, and so this would be our own system to do that and to do the full review of these maternal mortality cases.
And the benefit of that is really, I mean, we're as Senator Schwertner made some statements about like our challenges with the border and different things. Vast state from the Panhandle to South Texas, from the coast out to El Paso, very huge geographic state, and our challenges there. So we're going to have data very specific to Texas about maternal mortality that we can then take that data and say on our maternal mortality rates, this is how we can solve it. We really have been able to identify what the problems are.
That's our hope for this, is
Instead
like that
of
we
CDC
can
trying to direct maybe, oh, we think it's this, but it was getting, there were a lot of confluences and maybe not always pristine data that was driving the outcome. The outcomes were blurred because the data wasn't as pristine and scrubbed. Is that correct?
Yes, we're hoping to get very specific information so that it's actionable, so that we know what we need to deal with in what part of the state really to improve those maternal mortality rates.
10 million last session. I think you have an exceptional item to really finish it. Am I correct?
We do, yeah.
What exceptional item is that?
Exceptional item 8.
That's what I thought.
Yeah, and that's to really automate all parts of that system so that we don't have manual processes of people matching data outside of that system. They can be within the system. We can do data matching there, and we can do better analytics and reporting from there. And so just making it more efficient and more usable for us.
And it maybe then to Senator Zaffarini's point, exceptional item number 4, which she was pointing out was, it seems like a lot of the information there was awareness and education. But if you look at exceptional item 8, then we'll be able to track that and to know when congenital syphilis has impacted an outcome, a birth, a death. Correct.
This is mostly for the babies. We don't have a lot of maternal deaths due to syphilis, but if they are, then they would be caught in that system. The other thing that exceptional item 8 does for us is it helps us with that maternal and child health quality improvement system, where the hospitals can report data about quality, their quality measures, and we can get them back reports about if they're seeing improvements in their quality of care. And some of this stuff is going to fall under that quality of care improvement.
Thank you. Thank you, Madam Chair. Thank you for allowing us to fund that last session. I think that's going to be a really big deal for maternal mortality and us being able to specifically drill down and get to the actionable items that we can take as in the healthcare world.
Thank you. Thank you very much, Commissioner. Y'all are done. Thanks. No more
you.
questions. Okay, we're going to start with Department of Family and Protective Services, LBB presentation. Andrea Nisick, I don't know how to say your name. Agency presentation by Commissioner Muth and Leah Bigar, CF.